So, Assalamu alaikum once again. My name is Ibrahim Mohammed. I am in BSHB 5. So, inshallah, today I will take you through hematology review. So, inshallah, we'll go through the scope of our scope for today is we'll cover anemia in general and then specifically microcytic and macrocytic type. So inshallah, I want this session to be interactive. So inshallah, I will ask some few questions here and there for your contribution. So I won't like appoint individual to answer, but try to put the answer in the chat box, or you can unmute yourself. So inshallah, first we'll start with what anemia is. So maybe anyone can define for us in the chat box, or you can unmute yourself. What anemia is. Okay. So for the anemia, you have to say 4 things. Like in your definition, you must have reduction in hemoglobin in accordance to 3 things. Yeah, sex, you have to mention about sex. You have to mention about geographical location. Yeah. So now anemia will be defined as a condition where there's a reduction in hemoglobin concentration to below the lower limits of the reference range in a specified age, sex, and geographical location. Because it matters. For example, let's say in geographical location in a low altitude, like a patient will have maybe in case of the coastal area, the patient will have like when they have a slightly low HB, doesn't mean they have anemic. But in the high altitude, like the one of the Mount Kenya region, so if they have a slightly lower hemoglobin, that means they have anemia. So, and also I want us to go through the signs and symptoms of anemia. And by the way, what is the difference between signs and symptoms? So, yeah, Osman, HB below 12 for female and 13 for male. Yeah, you are right, but also make sure you put in geographical location, and yeah, it matters also for the sex. You have put it rightly. Anyone who can tell us the difference between what symptoms is and what signs is? Please, tuchangamke. Just say something, what you think of. There's no wrong answer. So the symptoms is like what the patient tells you. For example, they can tell you, I have a headache, yeah, and pain or sort of. But signs is what you as a doctor will elicit on a patient. Yeah, good. So symptoms is what the patient complains. Signs is what the doctor says, like sees on the patient. So the symptoms of anemia are as many as you can see. We have general weakness, easy fatigability, dyspnea, especially during exercise. We'll have palpitation, dizziness, like swellings, like edema of the legs, and on the face we'll see facial puffiness and so on. So for the signs, the most important one is pallor. Like you see the patient be pale. That's the most common in most cases of anemia. So the pallor is the most common, especially with severe anemia. The pallor, there is a 3 area that you can look for. At the palm of your hand, and the conjunctival of the eye, and the dorsum of the tongue. So if the patient is anemic, we'll see those three areas to be pale. And also we have a bounding pulse. So this is, you see on when you are like you palpate for you look for the radial pulse, and then like you hold like with the other hand at the forearm, and then you try to raise your hand above the level of the heart. So we'll see now the pulse of the radial area will be lost, and the one of the forearm, you feel like the pulse is hitting your hand. I think I'm clear on this. Maybe if you have any question, you can keep on, please, putting in the chat box. So, and also you will see edema that, as already told you, like pillow edema, the one of the leg, and the facial. In the face, you'll see the puffiness. And then we'll have the signs of shock like hypotension, tachypnea, and excessive sweatings as well. Now that is for anemia. And also before I go there, make sure you know like the normal ranges for RBCs, WBCs. That's basic, very important to know. Yeah, before you go to the complex things. Yeah, I also want to go, and we are just going in a summarized way so that we can easily understand, but this is not everything that you're supposed to know about anemia in general. So I want us also to go through a specific features of few types of anemias. Now, for iron deficiency anemia, we have cholinergia. Here is when we have like your nail is sort of carving outside or outwards. Yeah? And we have pica. Here is when we have like the patient is trying to crave for something. For example, let's say they try to eat soil or and anything. Yeah, so that they are trying. It's an alternative way of like they are trying to compensate for the iron lost. Maybe they are trying to find it through the such source. Inflamed or sort of. So in case of vitamin B12 deficiency, we have a neurological signs like peripheral neuropathies. Sometimes the patient experience like ataxic, and also they can present with beefy tongues as well. So for hemolytic anemia in general, they can present with jaundice, scalbosing, and splenomegaly. And I will show you some of the pictures of the pictures, what is scalbosing, how scalbosing look like, ready beefy tongue, how it look like, and so on. So for sickle cell disease or anemia, you can have dactylitis. That is like your fingers or hand, like will be inflamed. You can have hip joint deformities, chronic leg ulcers, and also there's what we call acute chest syndrome. Most of the sickle cell patients, they have what we call acute chest syndrome. That's whereby the patient will experience vaso-occlusive crisis, especially when they get like a small infection. You will see the patient have severe chest pain. Yeah, that is an emergency, need to be worked on faster. And then in case of Fanconi anemia, you can have skeletal deformities. So in the next slide, you will see the sport. By the way, they like to bring this kind of pictures, and then they will ask you which kind of anemia is this. So can someone tell me the first picture, the one on the left top right? Yeah, this one. What it is? Please. Yeah, please make sure you uangalie vizuri. So the first one on the left, this one, what it is, what picture is this? Like, what can you see on this picture? So the first one here, we can see the jaundice, and this is most common in hemolytic anemias. Okay, the next after this nail, This cholinergia, the one I've just shown you, this is for iron deficiency anemia. And then we have dactylitis there, the hand that is phlegm. And we have this is for a sickle cell, fitang, for B12 deficiency. And scalbosing is this one now. So our next scope is macrocytic anemia. So microcytic anemia is when we have our mean corpuscular volume, that MCV, is more than 96 femtoliters, but some books say 100 femtoliters. But according to your notes, will be 96 femtoliters. So the macrocytic anemia, they are divided into two types. We have megaloblastic and non-megaloblastic type. So for the megaloblastic, we have when we have a deficiency of B12 deficiencies, and also folate deficiency, that is vitamin B9. And for non-megaloblastic, we have like alcohol can cause non-megaloblastic anemia, and in case of hypothyroidism and liver disease, in this case it's non-alcoholic liver disease, and then medication like septrin, phenytoin, and those one can cause as well. So the investigation that you can do in this case, and then what you can see. By the way, this kind of question, most of the time they come in essays and also in the spot. After they give you the picture, they will ask you what investigation can you do. So for the full blood count or the complete blood count, in case of macrocytic anemia, we'll see your RBC be low, your hemoglobin will be low, and your MCV, that is mean corpuscular volume, will be high, above 96 femtoliters. On peripheral biofilms, we'll see macrocytes. And I will show you the picture of how macrocytes look like. You normally, like your RBC, you compare your red blood cell, you compare it with normally they are same size as the lymphocyte. So when it in the PPF, that's on the peripheral biofilm, when it is on a slide and you compare the RBC, the size of RBC with lymphocyte, you will see that in case of macrocytic anemia, the RBC will be larger than the lymphocyte. Normally it should be the same approximately. So if it is more than lymphocyte, the size of lymphocyte, will say this is macrocytes, macrocytic anemia. So ovalocyte is the same, and then in PPF we'll see hypersegmented neutrophils, but this one is more specific to megaloblastic than non-megaloblastic. So if you are given PPF slide and you see hypersegmented neutrophils, most probably this one can be either B12 deficiency or folate deficiency. And then, as you remember, the neutrophils normally have 3 to 5 lobes. So when it has more than 5 lobes is when you say hypersegmented neutrophils. So, and also serum B12 levels will be low. Serum folate levels will be low. Reticulocyte count also will be low. And we have what the test called methylmalonic acid, MMA, sometimes they write that in short. So methylmalonic acid will have elevated B12, but normal in B12. But in case of homocysteine levels, both will be elevated, like megaloblastic. What I meant is by in B12 and B9 will be elevated. And then because of the blood loss and everything, so LDH levels also will be increased. Lactate dehydrogenase level, and then intrinsic factors antibodies. You'll also do that. Let me explain you this. Yeah? So intrinsic factors is needed for the absorption of vitamin B12. So when you have a
I think if you can remember your physiology well, and in the stomach, the parietal cells will produce intrinsic factors. So, and then intrinsic factors is needed for B12 to be absorbed. So if you have problem with intrinsic factors, your B12 to be absorbed, so we'll end up having macrocytic anemia. Sheening test, and then for nanomegalocytic, you can do a LFTs to check for liver disease. You can do the thyroid profile for hypothyroidism and so on. So the next thing, now you can see the pictures here. This one, we have what we call angular stomatitis. Like the angle of the mouth is inflamed or sort of. So this is this is a suggestion of a B12 deficiencies. And the next one is hypersegmented neutrophils. Look, try counting the lobes of these neutrophils. So it is 1, 2, 3, 4, 5, 6, 7. You see, it is more than 5. So if you have more than between, normally, as I told you earlier, the neutrophils has 3 to 5 lobes. If it's more than 5, is hypersegmented neutrophils, which is a common features of megaloblastic anemia. That is, if you have B12 deficiency and folate deficiency. Now, this one is also macroovalocyte. Yeah. So I haven't put the one of the compelling neutrophils and the red blood cells, but I will send you an image. Take a look, inshallah. Okay, so the next scope is to go through microcytic anemia. So, as I told you, our MCV, some books say the normal range for MCV is some books say 80 to 100 femtoliters, but according to your notes, it's between 76.
So it is between 76 to 96 femtoliters. So if it is above 96, we'll say this patient have macrocytic anemia. Macro, that is, if it's above 96 femtoliters. And if it is below 76, we'll say this patient have microcytic anemia. Yeah. So in case of so when you see the patient have microcytosis is when the MCV is less than 76 femtoliters. That is for adult. But for the peds, the range is a bit lower when it is below 73 femtoliters. So the examples of microcytic anemia, I like to use the mnemonic tails. So T is for thalassemia, anemia of chronic disease, iron deficiency anemia, lead poisoning, and sideroblastic anemia. But before I go, I want to clarify something here. Listen very carefully. So in most of the cases, microcytic anemia is caused by iron deficiency, the majority of the cases. And in iron deficiency anemia, the MCV will be very low, like 50s, 40s, 60s there. But anemia of chronic disease, the MCV is slightly towards the normal. It can be even 70, like 74 or sort of. Like it doesn't mean like in case of anemia of chronic disease, your MCV will be a bit like towards the normal. Yeah, that is so. And then the next thing is to do lab investigation. Why they like asking question. You rarely miss this microcytic and macrocytic anemia question in essays and even in the spot as well. Yeah, so the investigation of microcytic anemia, they are divided into two types. We have hematological investigation and biochemical investigation. And then sometime in the question, they will ask you, what are the hematological investigation? Don't put the biochemical. If they ask you what are hematological investigation that you can do for this patient. So for the microcytic anemia, the hematological investigation that you can do is full hemogram. In full hemogram, you will see the RBC to be low, HB low, and also the mean corpuscular volume be low. On the peripheral blood film, that is on the slide, So we'll see microcyte. Now let me show you how microcytes look. So you see this picture, we are the blue things, the dark blue thing that you can see is a lymphocyte. And then you compare the lymphocyte and the side of adjacent RBCs. So you can see the adjacent RBCs is small in size. RBCs is these things that has central pala. So that is microcyte now. When it is bigger than this lymphocyte, will say macrocyte. So take a note here. So and then target cells is when we have like the central pala. I mean the central pala, and then there's like a dot in between. Like you see, the RBC will have central pala, right? And then we'll have a dot. I don't know if you can put it share here. I will cycle and send those cells, the one with target cells. You can see dacrocyte. Dacrocyte is specific features of iron deficiency anemia. And then in bone marrow examination, the iron is still blue when we are using Persian blue. So also here, this iron is still blue. So what I meant is, for example, let's say in case of iron deficiency anemia, you production stage now from the bone marrow, your iron is depleted. So you will see that the iron when you're doing the bone marrow, you won't find when you are using the Persian blue or the iron stain, that is, you won't see the blue color. But in case of anemia of chronic disease, we don't have problem with the store in the iron store in the bone marrow. But the problem is in the circulation, there is because of the chronic disease, the macrophages try to let me take a good example of TB, for example. So the macrophages try to engulf or take the iron from the body so that the bacteria won't use it for survival. So that's why in the circulation we have low iron, but in the storage at the bone marrow will have it will show blue. So that is it for the hematological investigation. For the biochemical investigation, we'll check three things. Number one, we'll see the serum ion. Number two, the total ion binding capacity, the serum ferritin level, and the percentage saturation of transferrin. So these two, they will like Kwanzaa, iron deficiency anemia and an anemia of chronic disease. They would like to play with your mind in MCQs. Which one is raised? Which one is low? Ama they give you a scenario. This is raised. This is low. And what condition is this? So make sure you are be keen here. So for iron deficiency anemia, everything is reduced apart from TIBC. So, but sideroblastic anemia is opposite of iron deficiency anemia, which means everything is raised except TIBC. So you have to be smart in cramming or getting this thing right. So for anemia of chronic disease, serum iron will be reduced, and then TIBC can be low or normal. As ferritin, as I told you, like you'll have in the storage in the bone marrow will be higher, but in circulation, that which is serum iron is low. So and also transferrin saturation is reduced. That's it, I think, for the scope today. So, and also last time I saw you guys, I was a bit held up. I will take you through your cut question, But if you have any question before we go to cut, please, you can unmute and or you can send through the chat box as well. Keep on sending. I've seen one. Keep on sending, inshallah. I will answer at the end of the presentation. So your cut question, hematology, by the way, is very easy, and then it carry a lot of marks. For example, even at the end of year and the cuts, the hematology will carry a lot of marks. For example, let's say sport exam. Sport exam, hematology has like 50 marks, and at patho has 50 marks, clean chem 20, and immuno 20. So, and then hematology is not a lot. You can divide into like, after you are done with like, it's 4 things. We have problem with the RBCs, problem with the WBCs, problem with platelets, and blood transfusion. That's it. If you put it that way, it will be very easy, and then you can easily capture it and understand it, and you can easily get your marks easily. And as part of is bulky, but also it's not hard. But make sure once like the hematology and clean chem, these small things will be in your fingertip, so that you can easily get your marks at an patho humana. But it doesn't mean that you will forgo an patho. So the question goes: write short notes on a 23-year female whose blood count show HB is 5.4, RBC is 1.9 times 10 power 9 per liter, mean corpuscular volume is 57 femtoliters, MCH is 17 picogram, platelet is 540 times 10 power 9 per liter, WBC is 14 times 10 power 9 per liter, neutrophils is 80%, lymphocyte 10%, eosinophils 8%, monocyte 8%. Now, yeah, they want us to write short notes on the following. Now, before we go, I want us to interpret. Okay.
Bra.
Yes.
Siri, let's just get someone to interpret this question, okay? Before
Yes,
you.
yes, sure. Yes, yeah.
Thank you.
Can someone interpret for us, please, and then give us the range, the normal range. If you say 5.4 is low, what is the range? RBC is, if you say low, what is the range? Yeah. And this range is very important. Kwanza, for full hemogram, make sure you know how to interpret. And the normal range is what? Sometimes, and also the differs with sex, as I told you earlier. And also WBCs. WBC, there's two types. There's the range, which is times 10 per liter, and the threshold, now this percentage. Okay, can someone interpret for us, please, for this result before you go to the question? Anyone to volunteer? Yeah, no, you say HP is low.
Bra.
Okay. Yes.
Just give out the ranges to make it easy for them.
Let them try Kwanza before I give.
Okay.
Okay. I can see Nuh say, yeah. Thank you, Nuh. You are right. Anyone else? For RBC, is it low or high? RBC low. Thank you, Abdi. MCV. Come on, guys. MCV, I've just said. Low. Thank you, Nadra. MCH. Thank you. MashaAllah. So platelet and WBC. Platelets high. Thank you, Abdi. Thank you. Shukran. For WBC. Thank you, Mustafa. Now we can go. Thank you. So what are the now presenting complaint of this patient? Understand what presenting complaint means first of all. Is it what the physician sees? I mean, is it signs or symptoms they're asking here? Here they are asking for symptoms. So you can mention as many as you can. The one you have just stated in the slide, like palpitation and others. Yeah, fatigue, palpitation, dizziness. And there are many that you can say it. You can put all the symptoms. Now the systemic inquiry. Here, I don't know if you have rotated in like I know you have rotated in P's and Obsgan and those systemic inquiry. Like what system? Like you have many systems. You have GI system, respiratory system, CV system, and the question that you will ask are what you would like to elicit in those systems. For example, let's say this patient, let's diagnose by there before you go. His MCV is low, so is 57 fetoliters. So can we say this patient has microcytic anemia or macrocytic anemia? Which kind of anemia is this? His HB is low, RBC low, MCV low, microcytic anemia. Thank you, Abdi. So the system, let's start with now GI. In the GI, what do you see? Patient with anemia. So we can see like blood in the stool or like digested blood in the stool. That's what we call malign stool. So in CVS, we can find palpitation, edema. In resp, we can have shortness of breath, sometimes also tachypnea. Yeah, so on and so forth. Yeah, this one is easy, just 2.5 marks. If you do this, you can get, I think you'll get all your marks. And then the next question is, the next question will be on the examination finding of this patient. Can someone tell us, please, the examination findings, what you can find? Now, this here, they're asking for the signs. Please you can send your answer in the chat box, please. The examination finding of this patient. Okay, focused occult blood in the system inquiry, yeah. Another finding that you can see on this patient. Very good, yes. No, thank you. You see your patient will be pale in the three area that I told you, the palm of your hand, the conjunctival, and the dorsum of the tongue. The other examination finding is many. I've just said when I was talking about the signs of the anemia. So in the you have like conjunctive, your patient will be pale, tachypnic, jaundice, yeah, so on and so forth. So the next question is what appropriate investigation that you can do? The investigation. Now, this patient is microcytic. So what investigation will you do? The biological one and the biochemical one that I told you. You can talk of those. So by the way, now for the biological, we're not going to say complete blood count because it was already given in the question. Note this, please. So if you, for example, here, like you are not supposed to put a complete blood count because it's given in the question. Like if you put in your answer, your first answer to be complete blood count and it's given in the question, that will not going to be awarded a marks for that. So now you can leave the complete blood count, and now we can talk of PBF, bone marrow, and the others. So in PBF, you'll have morphological changes and any abnormalities. Yeah, morphological changes is like we'll have like your in your PBF, you'll see the microcyte, and your RBC will be smaller in size if you compare to the lymphocyte. And then you can see abnormalities like dacrocyte in case of all the pencil shape. And the cells, your RBC will look like a pencil. the shape of the pencil. That is in case of iron deficiency anemia. You can see teardrop in case of thalassemia and so on. And then like your TIBC, those are the biochemical I was talking about, the biochemical investigation. So total iron binding capacity will be increased. Most probably in this case, it can't be the anemia of chronic disease. Remember, because of the MCV is low, it's very low. It's not like towards the normal or almost normal if it's in case of anemia of chronic disease. So your TIBC most probably will be increased. Transferrin saturation, you look for, you can check, and the serum iron, ferritin also, you will check those ones as well. I think that is the part of the question is this, and then the second question, your hematology second question was, is they need you to describe sometimes. So bone marrow failure. What by the if you are told describe, what are you going to say? Yes, you define what it is, how it is investigated, how it's come about, yeah, and then what cause. If you can put that 4, I think you can get your 4 marks easily. So bone marrow failure is inability of bone marrow to maintain the normal level of circulating blood. And yeah, what I meant is like in bone marrow is where our what you call hematopoiesis take place, like where the RBCs, WBCs, platelets, lymphocytes, and the rest are made. Or yeah, so now when we have the bone marrow fails to make those blood lineage, so that's when we say your bone marrow has failed. So, and this one is now, it's characterized by the features of when you have low RBCs, low WBCs, low platelets. So that is features of when you have low RBC, will have anemia. If you have low WBC, will have leukopenia. When you have low platelets, we have thrombocytopenia. In general, these three, if they like these three you have low of these three or totally very low, will have what we call pancytopenia. Pan means all. For example, if you have like all the 3 layers of your heart like inflamed, pancreatitis, you see? Pan means like all through. So now this one can affect one cell, one lineage, like only RBCs or platelet or all. So the mechanism how the bone marrow failure going to come about is through destruction. One, it can be through destruction of marrow tissue or suppression of normal hemopoietic cells, and mostly this one can be by, let's say, many things can cause, as we're going to cover it, like the cytotoxic drug, like methotrexate. I think we're going to cover those one in pharmacology, anti-cancer drugs. Yeah, will cause, and also the chemotherapies also can cause, which is the same as anti-cancer drugs. So yeah, and then now when we have now your cells, your hemopoietic cells being very low or not there, you'll have what we call hypocellular marrow. Yani your bone marrow will have low cells. Yani that's it. And now these cells now will be, sometimes it can be replaced by abnormal marrow tissues. That is in case of, let's say, myelodysplastic diseases. I don't know if you have covered myelodysplastic syndrome. Yeah, if you haven't, you're going to cover, inshallah, very soon in hematology. And now the clinical features of bone marrow failure can be anemia. This is when you have low RBC, bleeding tendency. When we have what? When we have your platelet be lower, will have a bleeding tendency. And when you have your WBC is low, or when you are leukopenic, you have increased risk of getting infections. Yeah, if you put that way, it'll be easier for you to get the marks. And then the next term that they want you to describe is I think hypersplenism. Okay, I want you to understand here also very clearly the difference between hypersplenism and splenomegaly. Like hypersplenism is when you have your hypersplenism means like hyperactive spleen. Yeah, any the spleen over distract your RBCs, or you know your yeah it over distract and overworks. In the small things, there's like let's say small infection, small things start destroying your RBCs and macrophages. And splenomegaly is like when your spleen enlarges and it's caused by several things like CML, infections like leishmaniasis, sarcoidosis, even polycythemia vera, many things can cause for splenomegaly. So hypersplenism is enlarged spleen leading to sequestration and destruction of the blood cells. And it's common and a common cause of hypersplenism can be liver disease, autoimmune disorders, and hematological malignancies. Okay. So, and the clinical features of hypersplenism can be anemia, just like the one of bone marrow failure, anemia, leukopenia, thrombocytopenia, and hypersplenism often most time lead to splenomegaly. You can diagnose hypersplenism through imaging to confirm splenomegaly and not ruling out other causes of cytopenias like bone marrow failures. Yeah, and maybe and also drug-induced pancytopenias. So the next terms or that they want you to describe is the hematological features of HIVs. So we'll have changes in HIV. I think you can. It's a lot. Yeah, I just put it 3. You can check your slides. It's a lot. The hematological features, and then they will tell you the HIV defining malignancies and HIV associated malignancies. Also, there they will ask a lot. Make sure you differentiate what HIV defining malignancy is and what malignancy that are associated with HIV. They are different. Take a look from your slide. So we'll have Rulox formation. We'll have your reduced RBC will be reduced, and also your platelet will be reduced as well, and also and white cells as well. I think that is all for me from my end. Jazakumullah khair.